Good morning. Let me once again express my appreciation to the organizing committee for the invitation to return once again to the Philippines. It is just wonderful to meet so many previous friends and to make so many new ones. This morning's presentation, as our chair just discussed, is really an extension of yesterday morning's plenary lecture, because what I want to discuss is there is gender disparity in coronary heart disease, and I want to examine with you whether this is bias, whether this is biology, or whether this is both. These are my disclosures, and let's begin with a little bit of review of terminology, defining health differences as compared with health disparities. And the question I'm asking is, when does a difference become a disparity? So if it is a disparity, the differences could be based on gender, on race, on ethnicity. They could be due to socioeconomic status, to education, or to income. They may even reflect environmental factors or the social context. They may be due to experience within the healthcare system. Very importantly, they may reflect access to or utilization and the quality of care. And then the questions that we have to ask is, are these avoidable or unavoidable? Are they unjust or are they just differences? Or are they inappropriate or even unethical differences? And those are some of the issues that we will discuss. And what I'm going to do is to go through the entire spectrum of coronary disease, the risk factors, the stable disease, the acute syndromes, the revascularization, and to discuss what we know about gender differences. And I will leave it to you to decide how many of these are truly disparities. Now, let's first look at something as simple as the basic coronary risk factors. And this is important when you talk to your women patients. If you have a patient who is a cigarette smoker, the coronary risk is 25% greater for a woman than for a man. As a matter of fact, this coronary risk of smoking is so high for a woman that most of the cardiovascular surgeons will tell you that they rarely perform coronary bypass surgery on a young woman who was not a smoker. So that is a very prominent risk factor for women. Diabetes has been called the great equalizer, because if you compare the diabetic women and the diabetic men, coronary risk is almost 20% for diabetic women compared with about 10% for diabetic men. And when you and I see a patient in the hospital with an initial myocardial infarction, about a fourth of the women have diabetes compared with about 16% for the men. And just start to look at that when you see your patients in hospital with an initial myocardial infarction. And then, not surprisingly, the coronary risk of the metabolic syndrome, where diabetes is such a strong contributor, is greater for women than for men. We mentioned yesterday pregnancy complications, and I want to go through this in a bit more detail today because some of this information is only recently acquired. And what we see is that with preeclampsia, with gestational diabetes, with pregnancy-induced hypertension, all of these are early indicators of an increase in cardiovascular risk and also the systemic autoimmune diseases. But I do want to spend a bit more time on the hypertensive disorders of pregnancy, because some people have said that pregnancy is actually the first stress test that a woman undergoes, and the metabolic stress of pregnancy has the potential to early predict subsequent cardiovascular risk. We're not sure whether there are basically shared risk factors for the development of preeclampsia and cardiovascular disease. I think it is not specifically the preeclampsia that causes the cardiovascular disease. But when we see a woman who's had preeclampsia, this is a routine component of cardiovascular assessment, and we've now identified a higher risk woman, and that might enable earlier intervention to prevent cardiovascular disease. Let me give you some idea of the magnitude of risk. The woman who has had preeclampsia, even during one pregnancy, has a 3 to 4 times greater risk of subsequently developing hypertension, and that can develop within the first decade while the woman is still in her reproductive phase. She has a doubled risk of ischemic heart disease. She has a doubled risk of stroke. And you know, we've all been taught that preeclampsia subsides with the delivery of the placenta, but the vascular complications do not. There is residual endothelial dysfunction that can be measured postpartum, and that has been associated with an increase in coronary artery calcium. And we all know now that coronary artery calcium is the equivalent of coronary atherosclerosis. So here you have a high-risk woman that deserves very careful surveillance and intervention for coronary risk factors. Now let's go on to stable ischemic heart disease. And probably the most important point that I want you to leave with is that angina is the predominant initial and subsequent presentation of coronary disease in women. It's different in men, where often they have no antecedent angina and are presenting to us with an acute myocardial infarction or, sadly, sudden coronary death. But because women have the antecedent stable angina, that gives us the potential to avert a myocardial infarction. And indeed, when we see patients in hospital with myocardial infarction, the men often have not had any warning previously, but the women have had warning with chronic stable angina. And this is why it is so important to be able to recognize angina, and it's not always the classic crushing chest pain. We've come to realize that there are many anginal equivalents in women: sudden dyspnea, sudden shortness of breath, sudden fatigue, and that the discomfort may be anywhere from the umbilicus to the jaw. And that becomes very important to recognize because it gives us the opportunity to intervene. Now, in the office, when you see a patient with angina, they generally tend to be older if they are women. The women are more likely to have associated hypertension, diabetes, and heart failure. And as we heard yesterday, that heart failure is far more likely to have intact ventricular systolic function. Obviously, the women are less likely previously to have had an infarct or a myocardial revascularization procedure. But as you look at population-based studies, there is a comparable prevalence of stable angina in women and in men. And therefore, I want you to think of the patients that you see in your office. If you are not seeing comparable numbers of women and men with chronic stable angina, stable ischemic heart disease, you probably are underdiagnosing angina in the women. Now, not only in the US, but we have abundant data from Europe. And this is a very interesting study, even though now it's almost a decade old. And it was a EuroHeart survey of stable angina. Maybe 3,500 patients, about half of them women, and they were diagnosed by a cardiologist as having stable angina. So this cardiologist said to the man and to the woman, "You have stable angina." Well, what happened? The women had a little bit less exercise testing, but substantially less coronary angiography, even though the classification of the angina was more severe. But very importantly, having diagnosed this, what did these cardiologists not do? The women received less statin therapy and less antiplatelet therapy. And at the time of this study, the only antiplatelet therapy was aspirin. And that was both initially and at 1 year follow-up. And obviously, since the women had less angiography, there was less revascularization, about half less. Well, what did this result in? This is a very prominent example showing you that over the period of follow-up, which was about 18 months, the women had a doubled occurrence of death and non-fatal MI, even when you adjusted for anything else. And the women who had confirmed coronary disease, those who had had angiography, had more angina at follow-up, about 10% more than the men. So the women certainly suboptimal therapy, and not surprisingly, suboptimal outcomes. Now, we just mentioned yesterday the WISE study, the National Heart, Lung, and Blood Institute Women's Ischemia Syndrome Evaluation, that, as I suggested to you, was paradigm changing. Because in order to get into WISE, the women had to have both chest pain and myocardial ischemia documented at non-invasive testing. So this is documented myocardial ischemia. And when they went on to coronary angiography, half of them had no flow-limiting coronary obstructive disease. Now, at the time of this study, what would have happened in clinical practice is that people would have shrugged their shoulders and said false positive non-invasive test. Now, that is a phrase I want you to get out of your vocabulary. That was not a false positive non-invasive test. It did show myocardial ischemia. It is just that that myocardial ischemia was not due to obstructive disease of the epicardial coronary arteries. And what happened is, because these patients were followed, because they were in a study, and they were not shrugged off, we found a great deal of information. These women had persisting symptoms of chest pain and subsequent occurrence of hard coronary events, myocardial infarction or coronary death. And what we learned from WISE is that even in the absence of obstructive coronary disease, persistent chest pain predicted cardiovascular events. So that one of our goals in these women is to control the chest pain by all means that are available to us. And here you see the three curves. In the green, and these are the women in WISE with 4-year follow-up. And when there was significant, more than 50% obstruction of the epicardial coronary arteries, you can see the percentage of problems. But even when there was minimal or no obstructive coronary disease, you see that there is both 2.5 and 6.9% of death and myocardial infarction. This is not just pain. These are hard coronary events. And I think this is a very important bit of information for your clinical practice. So how can we summarize the issues for women who have stable ischemic heart disease? They have less well-being, they have less ability to perform their daily activities of living, and most importantly, in terms of the economics and in terms of their quality of life, they have an increase in hospitalizations. They come to the emergency department and they are again and again admitted for chest pain symptoms. And the important feature is that both the severity of the symptoms and the degree of disability correlate very poorly with the obstructive disease. These women have a doubled mortality compared with their male peers, and when they come to angiography, even if they have obstructive disease, they have less severe obstructive disease, characteristically significant just one vessel disease. And that's because we women are just more complex. We have a much more complex pathophysiology. Certainly there may be obstructive coronary disease, but there may be separately or additively microvascular disease with endothelial dysfunction. And these women have a very high atherosclerotic burden. Often there's diffuse non-obstructive atherosclerosis that you can see very easily on coronary CTA with positive remodeling. And there may even be other features. We're still finding the entire spectrum. But I think this is very important for your consideration, because thus far, the only satisfactory therapies that we have are for obstructive epicardial coronary disease. Now, again, to summarize, Chest pain in the absence of obstructive disease is more common in women than in men. And again, even in the absence of obstruction, there is an adverse outcome. We're not sure what the mechanisms are. Certainly the underlying feature is myocardial ischemia. And the message I'd like to leave you with is that myocardial ischemia in women is what kills. But we still have to define how best to recognize it, and we certainly do not yet have satisfactory therapies for microvascular disease or non-obstructive disease. So here we see women with less anatomic obstruction of the epicardial coronary arteries having a worse prognosis than their male peers. And this occurs even in the setting of acute coronary syndrome. So with documented ECG findings, documented abnormal troponins, about 50% of the women whom you send to coronary angiography will not have obstructive disease in their epicardial coronary arteries. They are not candidates for intervention. But that does not mean that they do not require the same therapy, non-interventional, of an acute coronary syndrome, and that includes dual antiplatelet therapy for the recommended duration. We talked just a bit yesterday about Crusade, but let me explain it to you perhaps in a bit more detail. This is a quality initiative in patients with non-ST elevation acute coronary syndrome, a huge population, 35,000 patients, and a very good representation of women. 41% of the patients in this registry were women. And as I told you yesterday, the women with non-ST elevation ACS are a high-risk population. They have more death, they have more infarction, they have more heart failure, stroke, and transfusion. But when we looked at that registry, they were less likely acutely to receive heparin, an ACE inhibitor, or glycoprotein 2B3A drugs. And even at discharge, having been hospitalized for an acute coronary syndrome, documented, having that as their discharge diagnosis, they were less likely at discharge even to receive aspirin, but also ACE inhibitors and statins. Another problem is that the women in the Crusade registry had excess dosing of antiplatelet and antithrombin drugs. So many of these are either weight-based or creatinine-based. And that was associated with an increase in bleeding, an increase in mortality, and even the increase in bleeding protracted the length of stay, which is not good for the economics of care and most certainly not good for the patient's quality of care. And in the Crusade registry, about a fourth of the excess bleeding in women was due to the 2B3A inhibitors, and it was related to inappropriate dosing. So again, for your women patients, care with the weight-based dosing, care with the renal function-based dosing. And again, the Crusade showed us that the prognosis was worse in women. They were also less likely to receive coronary interventions in addition to not getting the guideline-based medical therapies. So why did they do worse? Is it that they had worse risk status at baseline? Is it that their therapy was less aggressive? Bias or biology? Now let me tell you another setting of acute coronary syndrome, and this is the Merlin trial. This is the TIMI 36 trial where the intervention was ranolazine. And as you know, ranolazine is not an ACS drug. But we learned a great deal from the Merlin trial because the patients all had 7 days of continuous electrocardiographic monitoring with Holter monitor. So there was 7 days of Holter monitoring on every one of the patients in the TIMI 36 trial. And they detected not only arrhythmias, but ischemia. And in Merlin, if there was angina in hospital, or if there was ECG ischemia on Holter monitoring, the women had more angina and the women had more ischemia in hospital, even though they had less obstructive coronary disease. And that ischemia was associated with a worse prognosis. Again, my message to you is that ischemia kills. Now let's go on to established myocardial infarction. And these are typically Q-wave infarctions. And no matter which series you look at, the women have a doubled mortality, and the difference in mortality by gender is worse for the young women, the women who are younger than 50 years old. You know, often when we admit a patient to hospital, a young patient with myocardial infarction, we say, oh, they're young, they're going to do well. Well, if they're a young woman, they are not going to do well, and the recently reported Virgo trial showed us why. The young women with myocardial infarction, and to a lesser extent the young men, come to their infarction with a huge risk factor burden, much greater than some of their older peers, and also some major psychosocial problems, particularly depression, that seem to have an adverse effect. Women who have an infarct are more likely to have a recurrent infarct than the men, and most importantly, more likely to subsequently have heart failure. And again, as we heard from several of the speakers yesterday, that heart failure is more likely to be heart failure with preserved left ventricular systolic function. In the American Heart Association study, as we talked about, the women had a doubled STEMI mortality, but predominantly in the initial 24 hours. And likely because they got less aspirin, less beta blockade, less reperfusion, and early reperfusion. And those are three of the interventions that we know improve survival. Now, this is not because there was discrimination. It was simply there was less recognition of myocardial infarction until after the initial 24 hours, and therefore we lost 24 hours of the ability to salvage myocardium. But I think what these data from the Get With the Guideline database shows us is that here are areas where we have the opportunity to improve care, to decrease disparities, and what has happened subsequent to the Get With the Guidelines and to the Crusade study, I think, is that the improved care of women has translated into the improved outcomes that I showed you yesterday. Now we have another source of information, and that is in the US, the National Registry for Myocardial Infarction database. And what do we learn from NERMI? Again, 1.4 million patients, 42% women. And what that tells us is that women are substantially represented among the patients who have myocardial infarction. These are data from the 1990s through 2006. And yet when you say, what are the trial data that we have for women regarding coronary disease, women represent only about 20% of the participants in clinical trials. So obviously we're going to have to do better. Now, what should you know for your clinical practice? The young women, here defined as younger than 55 years of age, are much more likely than young men to present without acute chest pain. They have acute symptoms, but they are predominantly dyspnea, fatigue, discomfort, aching, not the classic chest pain. So we must learn to ask questions that will elucidate these symptoms and just ask, what kind of problems are you having in your chest? And then you will get the discomfort, the heaviness, the pressure. And patients often are purists. They say it's not pain, it's pressure, it's heaviness, it's discomfort. But that is the symptom of myocardial ischemia. The young women have greater mortality than the young men in hospital, about 5% more, but that is substantial. But the absence of chest pain, of the classic chest pain, is associated with a delay in diagnosis, and that is associated with a delay in treatment. And as we looked at the NERMI database, we found out that it's almost 20 minutes increase in delay for women than men in getting onto the cath lab, and that's 20 more minutes of myocardial ischemia and resultant myocardial death. Now, here are patients who've had a coronary event. What about secondary prevention? And these are data now not from the US, but from 22 countries in Europe. And this is the EuroAspire survey. There's a subsequent survey that I've heard presented, but I've not yet seen published, that's about the same. the women across Europe had more obesity, had more hyperlipidemia, had more diabetes. And they were looked at in this study 6 months after they were hospitalized, either for an acute coronary event or for a revascularization procedure. And they had comparable drug therapy if you just do a checklist of the drugs. But the blood pressure targets, the LDL targets, the hemoglobin A1C targets were less often achieved in women than in men. The titration was not done appropriately for secondary prevention. And we heard yesterday the importance of titration specifically for blood pressure control. And of course, across countries, 55% fewer women are referred to cardiac rehabilitation, and this is where all the secondary prevention and the exercise training can occur. And we've seen that in all the U.S. cardiovascular guidelines, cardiac rehab has a 1A recommendation. So we are certainly not following any of the guidelines. Now I want to spend a few minutes talking about revascularization procedures, and particularly PCI for women. I think this battery is dying, so will someone please come and fix the computer while it is still alive? Okay, thank you. About 160,000 PCI procedures were performed in the U.S., and about a third of them, and this constitutes about a third of all PCI procedures. So women in the U.S. receive about a third of all the PCI procedures. And what we've learned from the trials, and particularly the COURAGE trial, and that has had applicability worldwide, is that there is no survival benefit if you compare optimal medical therapy with PCI and optimal medical therapy in the stable patient. We're not talking about the patient with acute coronary syndrome. And as a matter of fact, we learned the same thing in Barry 2D in the diabetic population, that in the stable patients, there was no superiority in terms of survival of revascularization and optimal medical therapy compared with optimal medical therapy and raw. But what you have to remember is that there is an enormous difference between the patients in a clinical trial and the patients that you and I see in clinical practice. In the clinical trial, all the patients were 88 to 92% adherent to all of the lifestyle recommendations and to all of the medications. Now, I think I'm a pretty good cardiologist, but my patients don't do that well. They're on 5 or 6 medications, and perhaps on Monday they'll take 2, Tuesday's a quiet day, they'll take 3 or 4, Wednesday they'll take 2 or 3 others, and I expect what we have to do is to see if we can get our community patients to do what the patients did in the randomized trial and to take every medication every day and do all the lifestyle interventions, and then we will see that there is benefit from optimal medical therapy as there was in the clinical trial. Now, PCI today has comparable outcomes for women and for men, both in stable coronary disease and in acute coronary syndromes. So when we look at the indications of the class 1 indications, there are no gender differences. But what we see is comparing the era of bare metal stents to drug-eluting stents, there was a greater improvement for women than for men with the drug-eluting stents. So this was a selective advantage for women. And again, as I suggested to you, even though women who come to PCI are older and have more risk factors, they are more likely to have single vessel disease than double or triple vessel disease. But with PCI, even appropriately done in the best settings, women have more bleeding complications, although they are a little bit lessened when the anticoagulation is less aggressive. But importantly, they are more likely to have acute renal failure, so that hydration and renal protection is particularly important. Let's go on to the bypass surgery, and this comes from that National Cardiovascular Network database, and here you see that the women are in orange and the men are in the green. And surprisingly, again, we are used to thinking of younger people doing better. And although certainly the problems increase with increasing age, but the younger women are at greater risk of hospital mortality than the younger men. You see the numbers, threefold increase below age 50, 2.5, 50 to 59 years. And with advancing age, the differences even out. Even though at all ages, women have better left ventricular function and fewer diseased vessels. Now, there's a doubled mortality in the young women, and one of the questions that's being raised, and I don't think has been solved yet, is whether there is less gender disparity with the off-pump coronary bypass graft surgery. One of the surgeons at our institution at Emory seems to think so. It has not been proved, but certainly either on or off pump, they still seem to do worse. And they have an excess of bleeding complications, and that etiology has not been determined. And very importantly, and our surgical colleagues have to pay attention to this, women far more likely to have depression associated with their bypass surgery than men. And depression is associated with bad behaviors. It's often associated with inappropriate eating, inappropriate smoking, less adherence to recommendations, less adherence to medications. So depression is very important to identify. And again, in the US, about 20 to 30% of all bypass surgery is done on women, and the guidelines from American College of Cardiology, American Heart Association, still define that women have greater peri-procedural morbidity and mortality, even though that has been declining recently. But the interesting feature, and it's likely because women are less likely to have multivessel disease, once they survive the perioperative phase, that's the challenge for the women, they have similar or better long-term outcomes than the men, even though they are less likely to go to cardiac rehab, et cetera. But over the long term, likely because they have less obstructive disease, women tend to do better. So how do I put this together? This is my checklist. I think the differences in pathophysiology are likely biologic because the women have a different spectrum of disease. I think the clinical presentations, because of the different spectrum of disease, are likely biologic. But when we talk about prevention and diagnosis and management and response to therapy and adverse outcomes, I think it is a combination of biology and bias. I want to spend just a moment talking about awareness and perception of women's cardiovascular risk, because this relates both to our patients and to us. And remember that your woman patient is unlikely to heed any of your recommendations if she does not perceive herself to be at risk. And in the US, we have had widespread educational and awareness campaigns, actually over a decade, since 2004, the NHLBI's Heart Truth campaign, the American Heart Association's Go Red for Women campaign. And what that did is it increased the awareness of coronary disease as a problem among women from about 30% to a little over 50%. Well, is that a glass half empty or is that a glass half full? Because the lack of awareness was greatest in the highest risk populations, and those are the US women of racial and ethnic minorities. But with this educational campaign, there was a decrease in cardiovascular mortality in women. But what about us? What about us as providers? It was a very interesting study of physician awareness and adherence to prevention guidelines. And what it showed is that among physicians, there were major gaps in knowledge and guideline implementation. And this was a computer-based study that had comparable cases, comparable risk factors. One had the picture of a woman, the other had the picture of a man. And uniformly, the physicians who took the test perceived the women to be at lower risk status, and that was associated with the suboptimal application of preventive interventions. So certainly we can do better. Now, here is where I think we have to go. We need gender-specific basic clinical cardiovascular research and then rigorous application of the emerging knowledge. This is the way we can improve cardiovascular outcomes in women. I think I've shown you that heart disease is at least an equal opportunity killer, but that gives us an equal opportunity to improve the outcomes, and I thank you for your attention.
Thank you, Dr. Wenger, for that very extensive and informative lecture. So in summary, we have heard that really there is gender disparity as far as treatment of cardiovascular disease in women is concerned, specifically when it comes to pathophysiology and clinical presentation. But we have to understand that this comes out to awareness as far as clinicians are concerned. So again, let me thank Dr. Wenger for this morning session, and I think she deserves another round of applause.